Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
This was a 10-year-old girl who presented to the emergency department following an injury to her left arm. So she was going headfirst down a slide and got her arm caught up and landed on an extended left arm. And then her mum brought her into the emergency department. She was later then transferred to the Children's Hospital. She's a fit and well child. She lives at home with her mum, dad and younger sister. She's got no known allergies and no previous injuries to this arm and no safeguarding concerns.
And what did you find on examination?
She was quite comfortable in a back slab. We just did a secondary survey to ensure there weren't any other injuries. This is an isolated injury. So her left arm was in a back slab. Just started by looking at her hand, which looked pink and well perfused. Because she was in the back slab, I couldn't get to the radial pulse to feel it, but checked the capillary refill time in her fingers. There was less than 2 seconds, and both her hands were equally as warm. Capillary refill, you can either do it peripherally on the fingers or centrally, but for this we're talking about peripherally. So you literally just squeeze on the end of a finger for 5 seconds and then release, and you're looking at how quickly the skin that's become blanched when you're pinching it then just returns to its normal colour. Normal capillary refill is less than 2 seconds. She was moving her fingers a tiny bit just on her own, but just from the end of the bed it appears that she had some motor function in her hand. We assessed that a bit more closely, so did neuro exam on her hand. Thumbs up, which is testing thumb extension, which is the radial nerve. The next thing I asked her to do was an OK sign, which is the opposition of the finger and thumb by a branch of the median nerve, which is the anterior interossei nerve, the AIN. I also asked her to sort of move and cross her fingers, which tests the ulnar nerve, and then as well just sort of looked and see if she could extend her fingers, again testing the radial nerve.
Very good. If you've got a younger child who won't cooperate, is there a way you could think of to get them to do that in a simple way that they'd understand?
So I've done it before where I just ask them to play with mum and things like that, see if they're willing to do that. Usually they're not particularly cooperative. The other thing that you can do to test the ulnar nerve if they're not keen to do that is sort of place a bit of paper or something between their fingers and then try and pull it away from them. And that's again testing the AB abduction of the fingers.
Great, okay. And also there's 3 of those things that you showed fits in quite nicely with rock, paper, scissors or paper, scissors, stone. So they can show the median nerve as a rock, paper as the radial nerve, and scissors showing that the ulnar nerve is working. Good, okay. Did you test sensation as well?
I did, yes. So for the median nerve, it's just on the index finger, the ulnar nerve on the ulnar side of the little finger, and then for radial nerve in the web space over the back of the hand.
Yeah. In the anatomical snuff box, if you bring your thumb up, you get a nice divot between the tensor pollicis longus tendon, and that's where you can see that quite nicely. Good. Okay. Fantastic. So essentially what we've got is a girl with a sore left elbow, normal neurovascular function, and now we've got x-rays that look like this. We've got an AP there, and there's also a lateral.
So these are an AP and a lateral radiograph of a left elbow of a skeletally immature patient. You can see some of the growth plates still. And there is a deformity of the distal humerus that you can see most clearly on the lateral view, which is what we've got here. If you follow the cortex along the anterior edge of the humerus down, there's an obvious deformity. And so I think this is a supracondylar fracture.
Good, yeah. We're looking at the elbow front on now. That's what AP, anterior-posterior, stands for. The fracture is, as we talked about, just going through there, okay? Catherine described it very rightly as a supracondylar fracture. So the condyles of the elbow are down here, and the fracture goes above the condyles. You also get supracondylar fractures in the femur because there are condyles there too. This is quite a common injury in children.
I just had a question about the lateral view. So I see the part where you drew the fracture line, I see a bit of a break going upwards. Is that a fracture as well? That one, yeah.
I think that's actually a continuation of this going up there. And I agree. On this one, it's actually quite subtle. The main break that you can see is through there. We're probably looking across to the other side of it. I think that white bit of bone, I don't think that's fracture. At the back here, can you see it's darker? And that's where blood has come from the fracture and is pushing the triceps tendon, which inserts onto the olecranon there. That's some space that's been filled by blood, and it's called a fat pad sign because it's pushed the fat and the tendon away, which is very suspicious for a fracture because fractures obviously bleed, and they bleed into whatever space they can get. And in this case, it's into that space there between the fat and the tendon. So this girl's been put into a back slab. Does everyone understand what a back slab is? We always talk about them in trauma meetings. Catherine, just run us through what the difference between a back slab and a complete slab is.
So a back slab is made from a single sheet of plaster that you wrap around part of a limb. But because it's a single sheet, there's a space that allows for swelling. So it supports the limb and immobilizes it, but doesn't restrict it circumferentially. So it does allow for swelling because you wouldn't want something to swell in a closed space.
The alternative would be a complete cast, which wraps circumferentially around the limb, and that's more of a long-term treatment. Good. Okay. She did sound quite comfortable. Why was that? Why do you think she was so comfortable? I suspect she wasn't comfortable when she first came in.
Yeah, so I think a lot of the pain relief for these children comes with actually immobilizing the limb. So putting it into a back slab will probably be the most effective measure. As you can see in this radiograph, the elbow's at 90 degrees, which it wasn't before. So getting her into that position was probably painful. In children, you can use standard analgesia like paracetamol and some opiates. But in the emergency department, some other things that you can utilize are gas and air, so Entonox, or things like intranasal fentanyl, which are really useful in children to give really quick and effective pain relief.
Good.
So you want to reassess her neurovascular status again. So the same examination I was talking about before, and make sure that nothing's changed since you've moved her arm.
What are we concerned about here, really, in terms of this fracture?
So you're concerned about the stability of the fracture. You can classify supracondylar fractures using the Gartland classification, which classifies fractures into 3 different groups. So Gartland 1 is a supracondylar fracture that is undisplaced, and that's quite a stable fracture that could be managed in a cast. Gartland 2, which is where the anterior cortex is broken, but the posterior cortex is sort of hinged open, so the posterior cortex is still intact. And then the Gartland 3, which is where it's completely sort of off-ended and the 2 parts of the fracture are definitely separated, and there can be sort of some angulation and things in that as well. And that's a very unstable fracture. So the more unstable it is, the more likely that you're going to need to use some sort of surgical fixation to keep the fracture in place while it heals.
Good. Okay. Excellent. The other thing which you touched on briefly is to do with rotation, which is another aspect of the reduction that we need to make sure is correct, because that affects the long-term outcomes of these patients. Let's say this was the morning and this patient was starved and she had been seen by an anaesthetist. What would be our next step? What are we going to do?
So I think you'd probably, because it's a Gartland 2, it's going to be fairly unstable. So you'd probably want to try and fix this. So I think if it's a sort of Gartland 2 like this, you could use K-wires to fix it. Yeah. You probably need at least 2 to stabilize the fracture.
And these wires they're called K-wires. K stands for Kirschner, who is a German surgeon. So you may hear the terms K-wiring, and that's precisely what's happened here. So these wires were straight when they went in, and then they get cut and bent, and you can see that she now has a complete cast, which is a fiberglass cast going circumferentially all the way around front and back and sides. Those wires would probably stay in for 3 to 4 weeks, and then they would come out in clinic. And then she'd probably go back into a cast for another couple of weeks just to avoid any mischief. And then at 6 weeks, they get her going. As younger patients, you get them mobilising earlier than that.
Following a manipulation, well, anytime you move a fracture, you need to check the neurovascular status again. So anytime you do anything to a fracture, so putting it in a cast or operating on it, you need to check the neurovascular function. So repeating the exam that I talked about earlier, and checking that the hand is pink and well perfused. You also want to be monitoring the patient's pain, which in children, is very, very important to make sure that they are comfortable. And it's very rare to see compartment syndrome in the upper limb, but if there was pain out of proportion to what you'd expect that wasn't being controlled by normal analgesia, which is worsened on passive movement. So if you sort of were bending the fingers, which would cause movement of the muscles in the arm, if that caused extreme pain, then you'd be quite concerned about that. So in this case, the first stage of managing a suspected compartment syndrome is to remove any external things that are on the limb. So in this case, I would remove her cast from her arm and release that and see if that improved the pain, because it could be an external compression from the swelling after an operation that's causing this. So that'd be my first step. I'd be escalating. So the next step, if you're very concerned about compartment syndrome, would be to test the pressures in the compartment, which you have a syringe loaded with saline, a little electronic box which tells you the pressure, and a needle, and put that into each of the compartments. So there are some other signs of compartment syndrome, pallor and pulselessness and paresthesia, but it's worth noting, I think, that pulselessness and pallor and change in sensation are really late signs, so you don't want to rely on those. I think these are most commonly extension injuries. So the arm is outstretched when you fall onto it.
If you fall on the hand and the force goes up through the forearm, pushes the distal part of the humerus, the far part of the humerus at the elbow in that direction, it's going to open up.
The less common type is a flexion type injury, but I haven't seen any of those yet.
The flexion types are about 1 in 20, and it's usually when you fall onto a flexed elbow and the force goes the other way. You fall backwards onto your elbow and the distal part goes forwards.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.